we have 0.01 and we'll soon get 0.05. So,
Yes.
so whom do we start 0.01 and whom do we start 0.05? I mean, do we still have any clarity on that, or again, is it
Yes,
based on
yes.
the
So
experience?
what happens is that, 0.05, 0.05 comes with a point that it is having a much better control, much stronger control compared to 0.01. In
Okay.
whatever data we have seen that 0.05 definitely is a much better drop compared to 0.01%. The only issue with 0.05 is that there will be patients who will be having complaints of some complaints of near work and photophobia. So the percentage of patients who have these complaints will be more with 0.05%. And here, the difference is that you will have around 7 to 8%. So around 8 people out of 100 would come back saying that this drop is not suiting me. So there are two strategies that you can do. What I do is that if the power is progressing much faster, and there is an article by Dr. Rohit Saxena, and they have used the word super progressors. We have been using 0.05% now since last 4 years. So the strategy is that if a patient is progressing faster than you would normally think of, you can start 0.05 directly, or if there is a patient who is progressing despite 0.01, you can start the 0.05 directly. Now, in either of the situations, you have to understand that whenever you start 0.05% directly, you have to tell the patient that, these are the side effects. Whereas with 0.01%, we normally would just give a blanket, line that nothing is going to happen. You can go ahead and put the drop. So with 0.05%, yes, we do tell them that these things may happen, and if they happen, you can come back, we will start 0.01%. If we are starting 0.05% as a primary therapy, having said that, we can always start 0.01%, gradually scale up to twice a day, and then if we feel that patient is progressing despite 0.01%, we can scale up to 0.05%. So if you feel that the progression is a lot more, like 1 diopter per year instead of 0.5 diopter, or axial elongation is more than 0.5 millimeters, whereas normally we would expect an axial elongation of 0.2 millimeters or 0.3 millimeters. So if you feel that progression is very quick, you can always start 0.05% at the first instance itself.
Okay. So one more thing again, just to like re-emphasize on the definition of progression. So that will be 0.5 for 6 months,
0.5 for 1 year.
0.5 for 1 year. Okay. And in the terms of axial length, it would be
0.2 to 0.3 millimeters per year.
Right.
So younger children progress faster. So for them, it is like they would consider a physiological elongation of 0.3 millimeter as normal. Now, this younger children could be under 8 years. Some studies or some workers feel that under 10 years, the progression can be 0.3 millimeters and it is still physiological. The lower limit obviously is 0.2 millimeter. And so children at 14 or 15 years of age may not elongate more than 0.2 millimeters. And so that is how they have decided a range of 0.2 to 0.3 millimeters.
Oh. And sir, in your experience, what is the maximum number of years you have given a continued of
5
atropine?
years.
5 years, sir. So
Yes, yes. 5 years we have given. We have given 5 years non-stop because patient wanted it. Patient finally was 18 years, stopped the drop, had a rebound, told the patient that, rebound is there, but you wait. And right now patient is around, I think he's 19 now, and he has -5. So he started with -3.5 at the age of, I think he started very early. This was, I think, when he was 14, 13 or 14 years of age. He was one of the first patient, like it has been 2017 or 16. I think the study which we did in 2015, 16, he was one of them, but he never stopped. So the first study which we did was for 3 years, from 2015, 16, 17, and we presented that in 2018. So that is around 10 years back. Now he has been operated for LASIK. in Delhi. Patient has settled in Delhi. A patient, I think, is a engineering student. So was a nephew of a gynec doctor. So he was a medical person's relative. This was before, before we had commercial drops available. We used to give reconstituted atropine. So what I can do is, if there are no questions, what I can do is I can quickly run through the slides. Maybe you will have some questions once I run through the slides. So this was the first slide, and this was just touching upon slide. Yeah, this was a slide where I was trying to tell that, atropine is not really new, and just that everybody is hooked to atropine since 2006. It was an RCT, and it was atom one study was 1%. But before even that study, you can see that 200 patients, 227 patients, RCT 1.5 years, 0.5% atropine, placebo versus single vision glasses, initial refraction of 3.3 years, and a treatment period of 1.5 years. This was a RCT for 8 years, 1%. So there were a lot of patients who, lot of work on atropine. This is a good article where they have tried to tell you what all what all authors or who all have done it in last 25 or 30 years. So this was just to talk about what is the mechanism. Nobody knows for sure what is the mechanism. I'm just quickly trying to run through the slides. So you can stop me at any particular slide. If you have any questions, you can just ask. So this was about what are the theories currently prevalent in the market. Like most of the things they have covered, they have tried to talk about retina, they have tried to talk about sclera, they have tried to talk about role of choroid. The problem is that it is very difficult to image sclera and choroid. So most of these are in vitro studies, and retina also. Now choroid, it is very difficult to measure the thickness in vivo, because although there are some swept source OCTs available, but still the point is that choroidal thickness is not very reliably measured. Although the theory is that choroidal thickness often precedes before axial eye growth, so the choroid actually thins out and it makes a way for the retina to grow in. So that is the theory that they are talking about in choroid. These are, in short, the theories which have been proposed as to how atropine works. Most common theory is obviously through the via dopamine receptors, and that is what everybody believes to be true. This was a little bit on whether it is the lens thickness which is getting affected, and the problem is there are again there are back and forth different views, and the difference which has been suggested between pre-atropine and atropine in the lens thickness is very small. So that is also a problem, that the difference in low dose atropine, according to this particular article, there was hardly any change. But when you use a stronger atropine, there was some change. Whereas Dr. Rohit Saxena et al. Suggested that the change was 0.03 millimeters, a very small change, and it is difficult to say that the retest reliability was as good as it was. These people also did a study, did not find much change in the whole work. Ashish has joined, and this was about how much change has occurred in lens thickness owing to atropine usage. Still, these are something which we really don't know whether really it is the muscarinic receptors, or there are some other signals which are also causing the or reducing the progression in myopia. This was the classical Atom 1 study where they had randomized controlled trial in 400 Singapore children. The eyes were randomized and not the children. So the problem was that it was between the two eyes, and so they could see that in the eyes which were getting atropine, they had a very small increase in power, whereas the non-atropine group had more increase in power, and kids were becoming anisometropic. And this was the long-term ATOM 2 study for almost 5 years. They did saw that atropine 0.01% were effective. And this was about, the fact that you can use atropine for a longer time, for 2 years, then a washout period, and then retreatment, not continuously. And obviously, they felt that 0.5%, 0.1%, 0.01%, everything was useful, but 0.01% was much more better compared, not better in terms of efficacy. In terms of side effects, there was hardly any side effect with 0.01%, and the effect was still there. Even if it was dose dependent, it was a significant effect. So the difference between higher concentration and lower concentration in ATOM 2 was not clinically significant, but the side effects were definitely different. This was a recent study, Atlas study, which was actually follow-up patients of ATOM 2 and ATOM 1 study, and they showed that the when you leave them for a longer period of time, after 10 or 20 years later, there was hardly any difference in the final refractive errors, and this suggested that you should continue for a longer time. Atropine should have been continued in these patients for a longer time rather than stopping it. The patient again catches up to the myopic progression, and so it highlights that longer treatment and continuous management is required in myopia till at least 17 or 18 years of age. So this was another landmark study, lamp 1, and this was followed by lamp 2. The crux of all these lamp 1, 2, 3, and 4 was that 0.05 is better than 0.025, which is better than 0.01, and long-term efficacy is very good. In fact, they shifted the placebo patients to 0.05%, and it reinforced that you have to give it continuously for 3 years, and there are no downside or no problems with that. They did suggest that rebound is definitely an issue with all three atropine eye drops. And so the phase 4 study was essentially for 5 years, and they continued atropine 0.05%, and they suggested that so they suggested that even if you stop at year 3, most of them needed to start it again after some time, because myopia was progressing. So that is what was LAMP all about. And it did say that it was a concentration dependent effect. And so they suggested that, most of the patients would need 0.05% rather than 0.01%. So this is another reinforcement, and it doesn't affect any other parameter. The poor treatment response is young age, parental myopia, and high myopia. So these are three non-responders which you have to be very careful. Even at the beginning itself, you have to know. This is the crux of all the ATOM and LAMP studies, that atropine eye drops do reduce the progression of myopia. Concentration is definitely concentration dependent, but 0.01% does hold value. We can increase the concentrations, and it may respond if it is not responding to 0.01%. This was something which we showed in 2018. This was our study, which we presented at AIUS in 2018. This was something about compliance. The compliance is in at least 14 to 15% of the patient do not comply. So since you have to put them for a long time, the compliance is not really good. This is about twice versus once, and we found that twice is better than once, at least in non-responders. So this was not head-to-head between 0.01% once or twice. This was between 0.01% patients who are not responding to atropine and were started twice a day, and what was their response rate. And this was between 0.01% non-responders to 0.05%. And Myotro Excel we did start, and we felt that almost 46% of the patients did respond to 0.05, who were earlier not responding to 0.01%. This was about pre-myopia. We have discussed this in detail in the pre-myopia talk, which was chapter 3 of this particular course. Yes, we have used it in pediatric cataract also. Although this study is about 7 children, we have many more children, and we tried to slow down the progression, the myopic shift in these children. This is just to show you how the rate of absolute growth and rate of axial growth reduced once we started atropine. And this was after 5 years of age, 4 5 years of age. And safety also, we did do higher order abrasions, but there is some concern that some of the patients may go for esotropia or esophoria sometimes. All these patients were actually post intermittent exo patients who were operated for exo, and they shifted from esophoria to esotropia. In our work, we have hardly seen allergy to these atropine eye drops, probably because the concentration is less. And I think this is the take home slide, how and when to start. So obviously we have the chapter 1, chapter 2 showed talk about documentation, and you record axial progression. In our, at least in our own experience, twice works is better than once. So if the patient is progressing quickly, we definitely would start twice a day, and we start it at least for 2 years and more only. We don't follow any upper age. We definitely want to look out for non-responders, so you have to constantly keep them and follow up. Younger children, parental myopia, high myopia, these are the things you have to look out, because these would be non-responders. And progression is definitely different in different age groups, so you have to keep that in mind, that younger children may progress faster compared to older children. So despite all this, if you go and look towards atropine eye drops, there are a lot of patients who are non-responders. If you see atom studies, if you see lamp studies, you would see that almost 31% to 55% of the patients do not respond to this. And so you have to move on to other therapies also. So that was so almost 25% of the patients would not progress even otherwise. So that is what is the placebo. So that is what I keep saying in my talks, in my lectures, that 20% of the patients would not progress whether you put them on drops or whether you don't put them on drops. So you should always try to start drops in patients who are progressors, and so you have to document the progression. In most of the patients, if there is a progression, only then you have to look for these drops or for glasses. So that was very brief. I just tried to finish it quickly. If there are any questions, you can ask.
So what is your follow-up once you start atropine,
So
either?
once we start atropine, we call them after a month, and after 3 months, and after 6 months. And then if the refraction is stabilizing, we would be calling them every 6 months. 1 month, when we start atropine, we tell them to come back after a month so that we can see their near point of accommodation. If there are any complaints, accommodative lag, pupil size, and we just want to be sure that there is no esophoria, there is no diplopia, patient doesn't have any photophobia. With 0.01%, I think in last now it has been almost 8 9 years, we have become very comfortable, very we have probably become more complacent than we should be. And now most of the patients, we tell them that nothing is going to happen, you can come after a month, but there is nothing much which is going to happen. We do have data for pupil size, photophobia, near point of accommodation. These parameters definitely change, but they are not really very significant. So if they don't change, it means that patient is not putting atropine. These parameters have to change, but they don't change significantly enough that patient complains, or there is a clinical issue, or patient says that there is a problem. So most of the children do tolerate atropine well. Regardless, you have to call the patient after a month, so that if there is a problem, we can take up the problem quickly, or if we have to switch over to some other modality of myopia progression control, we can switch them after a month.
Sir,
And
in Delhi, we have 0.01% of atropine. I
Yes.
seldom see any 0.2%. 0.02%, we don't see
0.02 is
anything.
not available, sir.
Yes,
0.01
sir.
and 0.05 is available.
Acha, what is the role of home atropine in case we want to try that?
There are no studies, sir. There is no data. One study is there which suggested that homatropine should be used, but nobody has followed up homatropine.
So you advise only 0.01% or 0.05% as you are mentioning, but that is also not available.
I advise both. No, it is available in Delhi, sir. It is available since last 1 month. It is available in Delhi. You
So
have
by which name?
to Excel.
Anji?
You have to write Myatro Excel, sir.
Myatro Excel.
Yeah,
By
that is
which
the
company?
Antod.
Antod. Okay, sir.
So
Thank you.
0.05% we use when we feel that myopia is progressing at a much quicker rate compared to, even otherwise. If the progression is like 1 diopter per year, then those patients may need atropine 0.05% directly. Otherwise, normally we keep it as a reserve drug and we use it when, patients who are not responding to 0.01%.
Good evening, sir.
Good evening, madam.
Sir, and at every visit of follow-up, a cycloplegic refraction is done.
No. Cycloplegic reflection is only after 6 months.
Okay.
So we also use, what we do is once the patient comes to our clinic, we will do cycloplegic refraction. We will give glasses and
Right.
we will not start atropine in the first instance. We call the patient again and record the progression. If there is a progression, we will start atropine or we will start glasses. We will not start it in the first instance. Once we start glasses or give atropine, we call them again after 1 month. When we are doing cycloplegic refraction, we also do axial documentation, which I was telling. And we also do ultra wide field fundus imaging so that we don't miss out on any other problems like peripheral, if there is a peripheral thinning or anything, we should have a record, we should have a data that this thing is there or not. So after we start atropine, we call them after a month, and cycloplegic refraction will be only after 6 months.
Okay. Thank you.
So you feel that usage of 0.01% atropine twice in a day is more beneficial compared to?
Yes, sir. Yes, sir.
And sir, we advise usually use this 0.01 eye drop only HS रात को सोते कर डालना है, or
Yes,
it
sir.
is
अभी नहीं रात को सोते वक्त ही डालना है. But if myopia is not being controlled or if the patient is progressing faster and if you don't have 0.05%, you can use 0.01% twice a day.
2 times in a day.
Yes, sir.
Okay.
Sir, most of the times it happens that the child has come for us for the first time, but he has already progressed. Previously, they will say that previously we had used these glasses and that the power has increased. But it is my first visit. They have come to me for the first time. So
Madam,
we only have now.
if you have axial length and if you have a data of axial growth, then you can start atropine because atropine works by reducing the progression through axial growth. It will
Correct.
stop the
Correct.
axial growth. So if there is no evidence, if there is no
Yes, sir.
evidence that there was axial length was not taken, or if you don't have any evidence of axial length, it is
Yes.
better not to start atropine. You should have your own data or somebody else's data.
Yes.
See, if I have done axial,
Even the previous data.
patient comes to you with axial length, you are measuring axial length and it is coming more, you can start. See,
Correct.
it is very easy to understand this. If you have a data of, if you have a data, like if you have a patient whose visual field or OCT was done and you have a data that RNFL thinning is progressing,
Yes.
only then you can, and there is an evidence. If there is no evidence, it will be very difficult for you to tell the patient why and what is being done. And for you yourself also,
Correct.
you won't know whether this patient, see, there are a lot of patients who don't do, lot of doctors who don't do cycloplegic refraction or leave
Yes, sir.
doctors. A lot of times these patients will not even go to optometrist. They will go to some optician. The difference between
Correct.
optometrist and optician is that the optician is actually a fitter. He fits the glasses and they also have
Yes.
an outlet. So they will also do autoref and keep the glass power and increase the glass power arbitrarily.
Yes, sir.
And these patients come to you, and when you are doing cycloplegic refraction, the refraction is actually coming less than what they are wearing. Now, patient has been
Yes.
referred to you
Yes.
for myopia progression. Patient's power actually reduces when you are doing cycloplegic refraction. So you just have to tell the patient that, see, I have done the workup. Let us wait.
Yes.
Your glass power is not going to increase by 2 diopters in 6 months. And if you are still concerned, you can come back after 3 months. Let us see. If they are too
Yes,
much concerned, you can call them after 3 months. If they are progressing by 1 diopter every year, they will progress within 3 or 4 months also.
yes, yes.
You can measure axial length after
Okay.
4 months.
Yes.
Try to have as much data as possible, because once you have data, no, when patient comes back to you saying that axial elongation is still there, or drops are not working, you should have data to back up that yes, this is happening. Because otherwise what
Yes.
happens is we are also caught barefooted, because we have absolutely no clue what we were doing. It may take some time for your practice to build up. It may take 3-4 months. But once, in your vicinity, people realize that you are trying to practice scientifically, patients will come. Gradually, they will understand that you have started the drops because there is an axial elongation. Not
Yes.
arbitrarily that the patient has come, you have just started.
Yes.
And sir, there is no age limit for this 0.01% atropine.
No, sir. We do start even at 17, 18 years of age if there is documented progression.
It is useful there also.
Yes, sir. Normally, after 18 years of age or even 17 also, sometimes, they stop progressing. So once they are not progressing much, we don't start. But it's a simple rule that we have to document that there is progression, then we can start.
So
Sorry. Please tell me. You are muted. I'm sorry. Yes.
yes,
Please tell.
no, sir. What is the role of AC by A ratio here when we are starting atropine?
No, honestly speaking, the role
Because
of
in the
ACI
last
ratio is.
presentation, I think
No, I was talking about accommodative lag, not about AC by ratio. What I was trying to tell was that, if patient has as a high AC by ratio, what will happen is patient will move into esotropia.
okay,
See,
okay,
what happens is if your AC by ratio is high and if you accommodate, because once you put atropine, your accommodation will be reduced by little bit, it will be reduced. But you can
yes,
overcome that amount of accommodation. Your accommodative power, if we what we have measured if you check on MEM method, your lag actually increases by 0.25 or 0.5. Now 0.25 or 0.5 lag is not really significant, but if you have accommodative AC by A ratio of say 8 or 9, what will happen is this 0.5 diopter will contribute to a convergence of 4 prisms. Even that
correct.
half diopter will get converted into 4 or 5 prisms. And when you are looking for near, you're already trying to accommodate for 3 diopters. And on add to that is the accommodative lag. So that may induce some esotropia or esophoria. So you should be just
Okay, okay,
careful that this is happening.
okay.
High AC
So
by
when we are doing the cover test, if we see that there is esophoria for near,
measure. Yes,
um,
yes. So there are two things when you are going and when you are seeing that there is esophoria, you have to do two things. One, you have to measure high AC by whether there is AC by ratio is high or not. Second thing is whether patient is already on accommodative lead or not. By lead, I mean that whenever you do a MEM method, you will actually see that
hmm,
patient is accommodating, which means
okay,
what is accommodative lag is that when you have given glasses to the patient and when you take your retinoscope and tell the patient to fix on a target just near to your glass,
yes,
just near to your retinoscope. Now, when patient is fixing on that particular target, actually there should be a lag of 0.5 diopter, which means that when you do retinoscopy, with his full correction, he should be, whatever is your distance, you correct for your distance, there will be 0.5 diopter lag, which means patient is not accommodating as much as it is needed.
yes, sir, yes,
But if patient is having esophoria, you will see that there is actually the lag, which is plus 0.5, would actually be in minus. And that is known as accommodative lead, which means that the amount of accommodation patient should be doing, patient is overshooting it. Patient is accommodating more than what is necessary. And because of that, the eye is going inside. So
hmm,
probably we have overcorrected the patient, number one. Number two, patient is going into accommodative spasm.
correct,
And normally, if you give them low concentration atropine, typically it was thought that in patients whose lag is less, this will help. But actually, it is the other way around. The moment you give atropine, the lag actually increases. So they thought that, sorry, not less. If the accommodative lag is more, probably atropine will work better in that. But actually, when you give atropine, the lag increases. Obviously, because it is, reducing the accommodation, even if little bit.
Accommodation. Correct.
It will increase the lag by 0.25 or 0.5 diopter. Although it is not very much significant. Whatever we saw in our work, we saw that with 0.01%, the lag increased by 0.25 or not 0.5 also, 0.25, or sometimes it did not change. With 0.05, it definitely changed more than 0.5 diopters. But in kids, that 0.5 diopter did not matter much. Even with near point of accommodation, we saw that there was the near point of accommodation actually receded by 1.25 diopters. But that also did not make much of a difference because their reserve was very high. But if you have a high AC by ratio, these patients may go into esophoria or esotropia. So if there is a high AC by ratio, I would say that it is a relative contraindication for higher concentration of atropine and not really for 0.01%. Because 0.01% is not doing much to the accommodation.
So even though there is high accommodative lag, low dose atropine will work in them.
Yes, it will work.
The parameters doesn't. Okay.
It is quite safe. What I mean to say is that when you calculate the accommodative lag, it is a good idea because once there is a problem, you know why there is a problem. If you have not seen accommodative lag before putting atropine, you have no idea why it has happened.
Correct. Okay. So if there is accommodative lead, then we can go for low dose atropine, but we need to keep a check of the parameter.
No. Then if there is accommodative lead, then you can go for 0.1% atropine also, because this patient actually needs to relax his accommodation. So you can give higher concentration of atropine also. Instead of 0.05, you can put 0.1% also, because this patient actually is accommodating.
Okay.
So it is other way around. Definitely it would help. It would relax his accommodation. Or patient is wearing overcorrection.
Thank you. So the concept of overcorrection, nowadays what I am seeing is that whenever there is slight exotropia or exophoria, invariably the prescribing ophthalmologist, he is overcorrecting spherical refraction by 0.5 or 1 diopter. But with that, the child is not able to see 6/6 vision. So now again,
see,
if I take off that overcorrection, the child is going into exo again.
So you mean to say they are giving overcorrection to treat exotropia?
Correct, sir. Correct.
Which city
It
is that?
I'm in
This is in
Varanasi,
Bangalore,
sir,
right? Huh?
I'm in Varanasi, sir.
Okay. No, what I would say is, I would tell you, see, overcorrection in intermittent exotropia was actually described very well by a lot of workers, especially by Jempolsky. This was something which he used, just to delay the surgery. Nowhere in his own records, Jempolsky has said that it would correct exotropia. So basically, why we are giving overcorrection? We are giving overcorrection so that patient can fuse and we can delay the surgery. Because the child is very young and we are not very sure what is his accommodative response, what should be the target. We are not able to measure. But at the same time, we want him to have straight eyes so that he can have his good binocular and fusional potential. So that is the whole crux of why we are giving over minus. Now, giving an over minus of 0.5 diopters doesn't change anything. If you want to give over minus, you have to give at least 1.5 or 2. Because that is what has been described by the people who do over minus. And they are doing it only for a short period of time. Short means 4 years. Not short doesn't mean 6 months. So they are doing it mainly to delay the surgery.
surgery. Okay.
Somehow this has picked up in last couple of years. And see, normally in our pediatric ophthalmic practice, this was not a routine practice, at least in our country. Somewhere it has
Yes, sir.
picked up that over minus will help. Yes, it will help, but you will have to over minus by around 2 diopters, which is huge. I mean, it is quite a lot.
Yes, sir. Yes.
And we don't know that this over minus, which will lead to accommodative lead because patient has to accommodate, because he has to use his accommodative convergence, and this may actually lead to myopic progression.
Okay. Yes.
That is also well known. There was a recent article where they said that, one author was saying that, it can actually lead to progression of myopia much quickly compared to if you give full correction.
Okay.
So the point which I am trying to make is that over minus, if you have to give over minus by around 1.5 or 2.5 diopters, which is quite a lot of over minus. So
Yes.
it is not a regular practice, and can be done in some few patients where you feel that, you want to delay the surgery. Otherwise, giving over minus and after a couple of years, you remove the glasses and then you have to do surgery. It doesn't add up.
And it might even cause amblyopia if we prolong it.
Yes, it can cause,
Because,
but normally, I mean, that is something that they have to keep looking. Otherwise, it can cause
correct.
myopia. Yes.
Because I've seen 2 or 3 cases where they have reduced vision, amblyogenic it has become, and now they have 6/12 vision with that over minus correction. So,
So I don't think that, I have never practiced over minus. I was never, in my fellowship, I was never taught. I worked with
okay.
Kushner. Kushner never did that. Maybe 1 or 2 patients he did give over minus, and he said that these are the patients in whom I know that I'm not going to operate very quickly. But he is very cautious. That was very, very few patients, not, not really a lot of patients in which he was using over minus. And so it never, picked up with me. Yes, if patient has plus 1.75 or 2, I may not give him plus 1.75 or 2. And thereby I am doing over minus. But I have never actively prescribed over minus, meaning if patient is emetropic or patient is -1, and I may prescribe -3. Normally, I won't do it as a practice.
Okay. Okay. Thank
So
you.
what is the youngest age at which you have given atropine?
21 years.
Youngest, sir.
Ajay, youngest is, I
Yeah.
thought, yes, okay. Youngest was 4 years.
Achha, 4 years.
Patient
So
was very
any role
close.
in these ROP children post barrage laser?
Again, you have to document axial elongation. So what, I mean,
Right.
unpublished data, I'm just telling you,
Mhm.
unpublished data, I have not published it, but I can tell you that most of these barrage patients, they do progress till 5 years or 4.5, 5 years. Then somehow they don't, probably that is the physiological growth which is occurring. Somehow after that, there are only 10 or 15% patients who elongate axially.
Okay.
And then if they are elongating axially, you may give atropine, but otherwise there is not much change in these. So what happens is they progress very quickly. See, the difference
Right.
between these barrage patients and normal patients is that typically a growth of 1 millimeter of axial length in a normal patient will contribute to around 2.5 diopters or maybe 2.25 to 2.75 diopters of myopia. In these patients, because lens and cornea is very crowded and ACD is less, 0.5 millimeter of axial growth contributes to 2.5 diopters. Now,
Right.
this is not, again, this is not really published or really discussed, but if you see these patients and try to calculate it mathematically, it would make sense because the anterior part of the globe, which is crowded, is a very strong, a very strong convex lens. And even a slightest increase is making a huge difference compared to a normal patient whose anterior segment is not very crowded.
Right.
So these patients progress phenomenally faster, and their axial length is typically 24, 25, and powers are like 12, 13. So they are not really axial myopes, but they do progress in first couple of years. I have never really tried or ventured into those years when there are 2 years or 3 years. Some of the
Okay.
patients we have measured axial length because when we do barrage, we do measure their axial length, and the eyeball is really small. And that is how we found out that, even a slightest increase in growth changes their
Mm.
power phenomenally compared to
Phenomenal.
normal patients.
Okay.
Sir, which machine do you use for measuring the axial length?
Right now, I'm using OBM12 and AL Scan 3 for which is normal my optical biometer.
Okay,
NIDAC
optical
optical.
biometer.
Yes.
But
Yes.
don't you see that if you done optical biometer, the axial length measured by two persons at two occasions, it may be different.
With biometer is
Yeah.
more accurate.
Okay, and with the physical axial length measurement
I
with
think
a scan or a
optical
scan or
biometer is more accurate compared to the contact A scan.
No, but with optical biometer also, the two readings may differ or it comes the same because we have not tried over there.
So Lenstar typically has done that study, and they have shown that they can accurately measure up to 0.01 millimeter. That is like up to 1 to 2 microns or 1 to 5 microns. Intertest variability up to 0.05, I would say, would be acceptable. And that is why 0.05 versus 0.3 is quite a big number. So if the increase is more than 0.2 or 0.3, only then we take it as a significant axial growth in terms of elongation of eyeball.
Right, sir.
There are no questions. We can close the meeting today. I will post this recording also.
Thank you, sir.
Thank you. Thank you, everybody, for joining.
Thank you, sir. Thank you.